When it comes to containing costs in healthcare, everyone has their 2 cents to give. But what do those of us in the business of health insurance have to say? This is Health Sense, and I'm your host, attorney Adam Russo, CEO and co-founder of the Phia Group, a firm with over 25 years experience navigating this ever-changing industry. Join me and my guests as we make sense of effective ways to reduce the skyrocketing cost of healthcare while improving quality outcomes for patients. The only thing it will cost you is 30 minutes of your time. So let's get right to the bottom line and reimagine what healthcare could be. Hello, everybody, and welcome to Health Sense with me, your host with the most, Adam Russo, the show that gets right to the bottom line on ways to reduce healthcare costs while always focused on improving quality outcomes for patients and their families. We are sponsored by the best company in the entire world. Yes, that's the Phia Group, the leading cost containment firm in the country, focused on ensuring that everyone gets access to the highest quality, lowest cost care possible. As always, please tune in 10 a.m. for you early birds, 6 p.m. if you're ready to work more after work, and for people like me that just can't fall asleep because they're just too excited to be alive, 2 a.m. Eastern on Healthcare Now Radio. As we all know, the main problem with healthcare in America can be tied to Einstein's definition of insanity, doing the same thing over and over again, expecting a different result. Folks, that's our current system. I just heard today here in my beloved state of Massachusetts, the insurance companies are going in front of the state insurance commissioner, and they're asking for an increase in the premium that's going to be allowed. Good news, it's less than what they asked for last year. Bad news, the average increase they're asking for, 13%. Now, I don't know how many of you are getting a 13% raise this year. I know my guest is. I know my guest probably gets more than 13% a year because she's so good. Anyways, based on the positive feedback we have heard from our listening public, we are doing another episode, part 4 of our 5-part series, and our guest was asked to come back because the overwhelming response has been amazing to the last few episodes that we've had, which are all tied to compliance and legal issues facing self-funded plans and brokers. Folks, if you think the topic is boring, it does sound boring. It's compliance, legal issues. Like people are like, oh boy, do I really want to go through 30 minutes of that? Well, if your guest was Jen McCormick, the answer is yes, you would. Now, what is the word of the day? Well, folks, what I realized is every word of the day is unique. And this one, because I want our entire session today to be about questions that brokers ask. One of the most recent and most interesting topics that we have heard. I figured today, the word of the day would be PGC referral. That's where all these questions come in, to PGC referral at phiagroup.com. Now, if you're still wondering who that guest is that got more than a 13% raise, it is Jennifer McCormick, the Executive VP of Consulting here at the Phia Group. Welcome, Jen. How you doing?
I'm doing great. I'm glad to be here. I'm glad this is being recorded, too. At least 13%, right?
Well, I said last year. I didn't talk about this year or next year. I said last year. But Jen, just so everyone knows, she graduated from the University of Indiana and as well as the Syracuse University College of Law. Jen, if I asked you which school, which campus was a better campus, just in general, Indiana or Syracuse?
Yeah, easy question. It's Indiana. Bloomington is a beautiful city. It's a great college town. I recommend anyone to visit, not just because of football or basketball.
Well, you know, it was always basketball, but now somehow the football team is good as well. Folks, you can see Jen at every podcast, many of the Phia Group webinars, our ICE forums. She's at conferences speaking all across the country, but she also is in many publications, such as the Self-Insurer and Benefits Pro as well. She joined us when she was 3 years old back in 2008. So she is only now 21. You can't see her, but trust me, she looks it. She does great, and her entire focus is on healthcare and regulatory issues that basically affect all self-funded employee benefit plans. So, Jen, first question. Okay, what is right now, if we're talking about right now, what is the number one topic that people are asking you and your colleagues at the Phia Group? What is it? Why is it that they're asking? And what's the answer you give them?
Yeah, I was just scrolling through some of the PGC referral questions that we have been getting over the past week. And maybe it's no big surprise, but a lot of them are about PBMs. And my favorite question so far is, if the PBM is making money off of our plan, isn't that in and of itself a conflict of interest for them to be our PBM? So a lot of this is popping up because we are seeing the landscape of what requirements must be part of the contracts, what it is that a plan sponsor must do, what the PBM must provide, what disclosures are being required to be provided at this point. And it's varying at the state level too. So different states are starting to put into place some of these rules about what it is that must be disclosed. So it's a really good question about whether and when there is a potential conflict of interest, if there is this pricing discrepancy in what is being charged, what is being paid, and what the actual incentive, commission, or pricing that the PBM is making. But that really seems to have been a really interesting topic when we're talking about transparency and whose responsibility it is to figure that out, to decide whether or not it is a conflict.
So is the answer different depending on what state you're in? Like, are there certain states that are, have a very specific, defined, narrow definition of transparency versus others where it's more the Wild West? Like, how is it different depending on what state we're in?
Yeah, certain states are, and a lot of this is pending, so there's nothing so much as effective right now, but a lot of the different states are looking for disclosures, and they want to know at every single level, every claim, what the cost was, what the billed amount was, what the paid amount was, where it sits on the formulary, the number of individuals, patients, or members that receive this. So in looking to put these different types of regulations in place, some at the different state level, maybe you're in California versus Connecticut and you have a totally different responsibility. This is not just an obligation on the plan sponsor, because really this is the TPA that has this obligation to work with all these different parties to find and collect all this information. So even though the goal is transparency, you have to consider the administrative burden and who this burden is going to be a part of it. And should there be fees or other considerations for compiling and managing and reporting and disclosing all this?
So let's say I'm a broker, right? And prior to my involvement, the plan was spending, I don't know, I'm going to make this up, $100 million on out-of-network charges, right? Claims out of network, $100 million. Broker comes in and looks at it and goes, man, we're definitely paying too much on these claims. But for the broker identified the best cost containment firm. The broker identified, worked with, maybe talked to 5 or 6 different firms, did an RFP, did an evaluation, identified the one to work with, told the third-party administrator, this is the vendor I want you to use, handled all the educational pieces, worked on the contract, made sure the implementation went flawlessly. And then now, the next year, the plan went from spending $100 million out of network to, let's say, $50 million out of network. But that broker paid himself a referral fee or a commission structure of, another $20 million bucks. So now total spend is 70, which is 30 million less than last year. And it probably would have been 110 or 120 this year, but for that broker's involvement. When we talk about disclosures, I'm assuming the broker is responsible to disclose all that, but is there going to be pushback? And is it right or not, Jen, in your opinion, that pushback would be, hey, you did save us $50 million net, but you charged yourself $20 million. You gave yourself $20 million for this work. Do we see a lot of that? And when it does come up, what is the answer that people are typically given?
Yeah, that's a good question. And there are certain broker consultant disclosure rules thanks to the Consolidated Appropriations Act. And this is either direct or indirect compensation, however it is that can be provided or received by the different entities that are out there. It is a broader scope for those different individuals, but that is why they're trying to have this reporting so that you can understand where the plan spend is going and how and whether this is contributing to the success of the plan. And I think the question that is part of your fiduciary obligation is not necessarily the number, the amount that they are making, or necessarily the amount that they have saved, but taking a look at the big picture, looking at the whole perspective here and understanding, but for this change, or but for this scenario, or but for us implementing this program, would we have potentially have spent $300 million instead of $100 million in this particular case? Because that is part of the monitoring requirement of the plan sponsor. So the amount in and of itself isn't necessarily unreasonable. It's looking at the big picture and all of the different components that make this program, because that is one of the things we're seeing in all of this litigation, is that you're not a bad fiduciary or a bad broker because the program that you implemented it was maybe more costly than the next program over, option B or option C. It's that you have a process in place, you have a program in place that is working to serve the plan members, because the plan member experience is what's critical. That's what you're looking out for. So that's what I would say. I would analyze the facts and the circumstances to do a reasonable test.
I would argue that, I agree, as long as there's disclosure there. But in my opinion, it's all about whether or not that broker can look at their client in the face and justify the charges they're charging. And if they could save $50 million for their client net, maybe $20 million a fee is a little excessive, but it really comes down to how much effort and time. Are they just making, a 5-minute phone call to get a new vendor in place? Or are they truly involved and invested in making the change and making sure it goes smoothly? Because obviously, what we want is, I look at it this way. For so many years, so many individuals, consultants, brokers, etc., have been paid based on the overall cost of the plan. I have seen situations in plenty of contracts where a consultant will get paid more if their premium goes up. They're literally paid based on a percentage of the overall premium. Whereas a shift to, if I'm able to save you money, my payment, my reward is a percentage of the actual savings that I am able to bring to the plan. That is how the Phia Group gets paid overall. And I feel like that's the shift that we're seeing. Do you see that shift as well? What are you seeing in regards to how compensation is being done? Is it more flat fees? Is it more percentage of savings? What are you seeing out there in the real world?
Yeah, I think it's tricky, but we're starting to see more of these capped sort of arrangements because the cost of healthcare is going up. And as we're starting to see the cost of everything else go up, that means that the cost of the different fees and the commissions are also going up. So having some sort of model where you are understanding and contemplating the different components, the increase in the cost of healthcare, the complexity of the program that needs to be administered, the continuing awareness and education and monitoring of that program, all of those pieces need to be part of it. So maybe today it's not as reasonable to have an unlimited commission, percentage of savings, percentage of bills fee than maybe it was 10 or so years ago. We weren't seeing these claims at such an all-time high for the cost of healthcare. I think that's contributing to part of the problem. And that is your fiduciary obligation to make sure that you, as the plan sponsor, have reviewed that contract and you understand the limits, the restrictions, or any of the guardrails that might be in place. Because maybe it is appropriate up to a certain amount to have a percentage type of commission in place. But only once you hit a certain threshold, maybe that's where the amount for that deliverable that you are producing maybe becomes a little bit unreasonable, and you, plan sponsor, are responsible for watching that and managing it, or otherwise it's you, plan sponsor, that's going to get sued for not paying attention.
Very good. Folks, if you're just joining us, my guest today is Jennifer McCormick, the Executive VP of Consulting at the Phia Group. I am your host, Adam Russo, and again, welcome to Health Sense here on Healthcare Now Radio. All right, Jen, we went over one or two questions. What else? What other big topics are coming in? You're answering. What head scratchers do you see out there in the marketplace as well? Anything that you can do to enlighten our amazing listening audience?
Yeah, I think another really big topic, and we have seen this all throughout the headlines, we're getting questions about ICHRA versus self-funding with maybe a captive or another type of an arrangement. And the question, because we are seeing these rising healthcare costs, is an ICHRA the better option for me? And ICHRA is a standalone individual plan that an employer can offer for their employees. And in the self-funding space, part of what we're talking about is how we can have transparency and control, understand costs. We can get claims data. We can get access to things. We can put plan design in place that makes sure that we're targeting certain individuals so they can get the care that they need and they want in a way that makes sense. And we're able to manage that message. And then when you have this ICHRA, there are certain things about it that sound more attractive, that from a budget perspective, it's easier to forecast when you're giving $500 a month and you don't have to worry about it. But then again, you're giving up all of the control because you don't have any idea about how these claims or these funds are being used, the types of benefits that these individuals are receiving. And you're almost putting them on their own to say, here you go, here is your pot. And you can use this money and find your own providers, find your own plan that works for you. But I can understand that if you're looking from a forecasting perspective, you know what you'll be spending, so you can budget differently.
For those people listening that have no idea what you're talking about as it relates to a captive versus an ICHRA, let's go over the captive first. Explain, obviously we've seen captive market explode over the past 10 years. There's no question about it. I could think back to 15 years ago, maybe 2 or 3 captives out there in the self-funded space. Now there are over 20. What is it, Jen? What is a captive? And then, what's the differences between them? Are they all the same? Does it matter which one I pick? Let's answer that first.
Yeah, so a captive traditionally, or it started out at least, where it was a really great option for some smaller employers to work together where they could help manage the risk. So when you are self-funding, that's one of the things that you need to worry about. If there's catastrophic insurance that you could put in place to make sure that if there is a high claim or a high risk individual, that you are protected. And having stop loss can sometimes be very expensive. So a captive is almost this middle layer between the self-funded plan and the stop loss, where you can work together with a bunch of different individual employers and manage that cost, maybe putting programs in place together, having some commonality in programs that you're offering for the different employers. And it was a way for some of these employers that maybe weren't necessarily sure about self-funding solely with stop loss. This gave them an option that they could pursue.
Okay, so that's the captive piece, right? All right, you want to keep going again?
Yeah, on the ICHRA side, it essentially is in individual coverage HRA, ICHRA, ICHRA. And this was created only 5 or so years ago in line with COVID. And this was something that was allowing an employer to give their employees a certain amount of money in an individual HRA that they could then use that money and then go to the exchange or go to Blue Cross to buy an individual policy that worked for them. So the options here are the employer has a plan that they are sponsoring versus the employer gives each individual $500, name your figure amount of money for them to buy their own insurance individually by themselves without that support from the employer.
All right, as an employer, right? I'm sitting here going, wait a second. You're telling me I have a couple different options. One, I could be fully insured with a premium that is extremely high, right? No control over the plan in a fully insured situation. I would expect that my premiums will increase by at least $1,000 my premiums to increase by at least 10% a year. It's never going to go down. We know that, right? Mm-hmm. Automatic 10%. I could self-fund traditionally and have stop loss at a certain dollar amount, $50,000, $100,000 per individual per year. Okay. And there's a maximum there, but you really don't know how much you're going to spend because you have no idea how many people are going to get sick. I could do a captive arrangement where I'm sharing that risk, as I'm a small company, with other companies, hoping that this larger volume of people on the plan will spread that risk to ensure that I'm not getting crazy increases or crazy amount of high dollar claims that we have to be responsible for. Or I could do this ICHRA, where I could say, you know what, Jen, I'm going to give you $750 every month. You do whatever you want with it. If you use that money to get really good insurance and it just supplements a piece of it, or you use that money to get really cheap insurance that's not good, it's on you. Why wouldn't every employer just do an ICHRA?
Yeah, there's pros and cons to both options. And why wouldn't you do an ICHRA? Because then you have control over your budget, you have control over your forecasting, but you don't have control over your spending. So you have no idea about the options that are available to the individuals. And also, you maybe care, if you're an employer, about the member experience, because this is an employee benefit that we're talking about. So if you are letting your employees loose with the ICHRA model, you are putting them in control of the shopping. They then have to make all the decisions. And I love shopping, but shopping for healthcare is complicated. It's nuanced. You don't know if you're going to be able to keep your same providers. You don't have the transparency or the insight to it. When you have a captive arrangement, for example, that's where the employer gets control of the spending. They get to design the plan, they get to design all the different options, and make sure that they are inviting some of this transparency that you don't get on the ICHRA. So it really is an individual employer choice, but there's pros and cons with an ICHRA.
Well, the bottom line is, again, as an employer, again, it's an employee benefit. No different than, pay time off, no different than, holiday pay, overtime pay, whatever benefits that you can give to your employees, whether it's a discount on food if they work at a restaurant, whatever it might be, it's a benefit. And as you're trying to attract employees, especially here at our company, one of the things that we know is, we tend to hire younger people who are beginning to start families, getting married, having children, and having really good health insurance matters to people when they have children, right? It does. So being able to offer a benefit that helps those employees in their time of need, or when their child is sick, or their spouse is sick, or they're sick, really keeps people wanting to stay at that place of employment versus taking the chances of what their insurance coverage might look like. So great answers to those questions. What else, Jen? Last question we got time for today. This has been fun-filled, a lot of great stuff. What's the last big thing that you're hearing about, seeing, and what do you have to tell our listening audience about it?
It wouldn't be me if I didn't bring up plan documents.
Of course, your favorite topic, Jen.
Yeah. My favorite question is, if nobody is reading these plan documents, does it really matter if it's not compliant? If a tree falls in the forest, does it make a noise? So I think that is a common question that we're getting is, all right, I don't know if my plan document, if it's compliant. No one is reading it anyways, but I want to make sure at the same time as I don't want to make any changes to this document, how am I going to be able to lower the cost? How can I keep the plan as is, but make people have lower costs? And how can I reduce the spending on this? And I think that is really hard and difficult to decrease the cost that you are seeing in your plan without making or being willing to discuss any sort of plan design changes. And that goes back to the days in the beginning of ACA when everyone was so afraid to change from being grandfathered to a non-grandfathered plan. It was critical that they maintain that grandfathered status because they were so scared of offering preventive benefits at 100%. That was the downside of it. And I think that's the same analysis here, is that people are so scared to make these changes, but the changes that you can make, yes, it might be an extra step where you need to make an amendment, but you have the opportunity to negotiate provisions, maybe negotiate with certain vendors, implement programs, change some of the exclusions, strengthen some of your subrogation language, and it can save you a ton of money. That's really the key, is being willing to be flexible and adaptable as the market is changing. We need to evolve.
One of the craziest thing I've seen is the reality is on out-of-network claims, how claims are paid. I remember the old days, it used to be provision called usual and customary. And there are still plans. I mean, we have literally told people at least 15 years now to get rid of that archaic language. And then we took it from usual because, folks, here's what how I used to tell it. If I usually rip you off, then that's the usual price. Then that is the customary price. I'm usually ripping you off. That means I can continue to rip you off on what I'm charging you if the definition says I will reimburse you, pay your claims, as long as they are the usual and customary charge. So if I usually charge you too much, that's what you got to pay. So we then told people to change it to reasonable. What's a reasonable amount? Now more and more people looking at maximum allowable. What percentage of plans, Jen, I know I said last question, but it's still part of the original last question. What percentage of your plans would you say that you see still have the archaic language on an out-of-network claim, would you say?
If there are plans that I've reviewed and commented on that don't have our language, more than I'd like to see. I don't know, 30 to 40% still have this language that is not appropriate at this point in time.
That was a nice way to put it, Jen. I know what you really wanted to say. But the bottom line is, folks, on a $100,000 claim, you realize on an out-of-network claim with the wrong language, you could be on the hook for $100,000. By changing one sentence, you are now looking at a payment of anywhere from $30,000 to $40,000 on the same claim. One claim, one sentence change, $60,000. Same thing when it comes to reimbursement rights, subrogation rights. We're talking a ability to get reimbursed when a member is in a car accident and collects $1 million policy. You're actually able to recover all the money that you've paid on behalf of that patient for their accident they were in. You can recover it all back with the right language, or if the wrong language is in there, not as strong, your right to recovery would be literally zero on the same situation. So what your plan language says truly matters. Jen, any last words before I have to let you go?
No, I think the takeaway for me is that cost containment or cost savings is not an isolated provision change here or there. It is part of a more complex strategy. And more than that, it's an obligation or responsibility of the plan sponsor as a fiduciary.
I couldn't have said it better myself. Well, maybe I could have. Who knows? But folks, that is all the time we have for today. Jen, as always, it was a pleasure. We'll see if the people want you back. I hope so. But folks, on behalf of my guest, Jennifer McCormick, the Executive VP of Consulting at the Phia Group, and your host with the most, Adam Russo, thank you for joining us here today on Health Sense. And as always, go Cleveland Guardians. Have a great day.